Welcome, friends and colleagues, to the third plenary session of the 2021 North American Cystic Fibrosis Conference. My name is J.P. Clancy, and I am the Vice President of Clinical Research here at the CFF. We gather virtually again this year to review and share the latest and most exciting insights in CF care and research, including recent developments in clinical trials. The tremendous advances that are being realized today in CF build upon work and commitment of many talented people who helped pave the way for our current success. Today, we remember one of those past leaders, Dr. Richard Talamo, and present this prestigious award named in his honor to one of the giants of adult CF research and care. After graduating magna cum laude from Harvard College and earning his MD from Boston University Medical School, Dr. Richard Talamo pursued a career in pediatrics and became an NIH clinical fellow in the laboratory of Dr. Paul de Saint-Ignace, where he developed a lifelong passion for understanding CF and caring for those with the disease. While a professor of pediatrics at Johns Hopkins, Dr. Talamo became deeply committed to the mission of the CF Foundation and served in many ways, including on the Medical Advisory Committee and also on the Board of Trustees. During this time, he helped raise interest in CF and encouraged researchers to focus on this disease. Dr. Talamo returned to Boston in 1980 as the chairman of pediatrics at Tufts University. But sadly, this brilliant and caring man died prematurely at the age of 47. The Richard C. Talamo Distinguished Clinical Achievement Award recognizes individuals who have spent their careers researching and caring for people with CF, and his contributions have significantly impacted the disease. This year's recipient has had a highly distinguished career in CF for over 40 years, with huge impacts that cut across care, training, and clinical research. This year's recipient is Dr. Dick Simon, MD and Professor Emeritus in the Department of Internal Medicine at the University of Michigan. Dr. Simon completed his Bachelor of Science in Mathematics at University of Michigan, followed by his MD at Duke University. After a research fellowship at Duke, he completed an internship and residency in San Francisco. He then went on to a chief residency and fellowship in pulmonary and critical care at the University of Colorado, followed by research fellowships in Colorado, the Francis S. North Foundation, the United States Public Health Service, and the NIH. He then returned to Michigan as a faculty and has been a Michigan man ever since. Dick has had a long and storied career in academics and in CF, with a tremendous impact on the entire CF community. Thank you, Dick, for your dedication to the care of CF patients, for ensuring their safety in the development of new therapies, and for your contributions to the next generation of CF clinicians and researchers. I would now like to share with you a video that highlights some of his many contributions to those living with CF.
Dick, congratulations on receiving the Talamo Award, and thank you for your decades of service of people with CF, their families, and the whole CF science and care community. Your selfless leadership is something we have all aspired to, and that leadership has enabled so many of the advances that make up the remarkable story of CF, from establishment of adult CF care, to the development of transformative therapies, to the formation of the next generation of CF caregivers. And a little known fact that may be of particular interest to those at this meeting. For the last 15 years, you have done a remarkable job of leading the design of all the clinical content programming at NACFC. You truly are a man who has never said no to a request to lead or serve on a project that would advance CF care and research. So on behalf of the CF Foundation and the whole CF community, we say thank you, thank you, thank you, and congratulations.
It's truly an honor to say a few words about Dick Simon. In my earliest interactions with him, it was clear that he was an independent thinker who listened before he spoke. And when he spoke, everyone listened. With that insight, I often turn to Dick when facing big challenges. He has been an inspiring role model to me and many others. Many thanks and congratulations, Dick.
Congratulations, Dick, on your well-deserved award. In your role as Vice Chair of the Cystic Fibrosis Foundation Data Safety Monitoring Board, you've materially contributed to the many advances we've seen in CF therapeutics over the last 2 decades. My good friend, I am just thrilled you're receiving the Talamo Award.
I think everyone who has worked with Dick appreciates his very methodical and calm way of approaching a problem. Dick is the person we all call when we want to run something by someone else. Dick, thank you so much for always being that great sounding board. Congratulations.
I've had the privilege of working with Dick for my entire career. As one of the leaders of our data safety monitoring board, he has ensured the safe progression of so many therapies, most notably our CFTR modulators, through our clinical trial pipeline. What I admire most about Dick is his ability to ask really tough questions that help us challenge precedents. Congratulations, Dick.
Dick, congratulations on receiving the Talamo Award. From my perspective, you've been a tireless advocate for both progress and safety in research throughout your leadership on the Foundation's Data Safety Monitoring Board. And you've also done this as a valued member of our TDN Clinical Research Executive Committee. Thank you for everything you've given to the CF community. And again, congratulations.
I am privileged to be one of your mentees and to have worked with you on some of your CF activities. Thank you for doing so many things to help CF, particularly in adult care. It is inspiring to see this well-deserved recognition.
Dick, you have been such an amazing role model to me and to so many other people in the CF community. Your thoughtful approach to patient care, to clinical research conduct, and to faculty development have bettered the lives of numerous people. It's my privilege to call you a colleague and a friend, and to have this opportunity to congratulate you for this well-deserved recognition. Congratulations, Dick.
Welcome back. What a lovely tribute to Dick Simon, a true leader, provider, and innovator in the CF field. Now on to plenary number 3. As noted earlier, this has been a tumultuous year for all of us. The ebbs and the flows of the pandemic have created new challenges to the conduct of clinical research, but research teams and participants have adapted masterfully and have been able to push important work forward. The third plenary focuses on research to bring novel therapies to all people with CF. This includes highly effective modulators, treatments that substitute for missing CFTR, and ultimately genetic therapies. This last topic is part of the Foundation's larger Path to a Cure initiative aimed at advancing treatments to a cure. And amazingly, some of these therapies should enter clinical trials in this coming year. Genetic therapies ultimately have the capacity to benefit anyone with CF, regardless of mutation. It is my pleasure and honor to introduce the plenary number 3 speaker for the 35th Annual North American CF Conference, Dr. Manu Jain. Manu and I have a lot in common, including our birth year, our undergraduate major, the number of kids in our families, our career commitment to CF, our frequently disappointing football teams, his in Chicago, mine in Cincinnati, and our mutually graying hair. But all kidding aside, Dr. Jain has had an impressive career in CF care and research. Manu graduated with highest distinction from Northwestern with a biochemistry degree, followed by medical training at the University of Chicago. His interest in research surfaced during this training, including a Howard Hughes Scholarship for Research Award during medical school. He joined the Northwestern faculty in 1996 and became the Director of Adult Services for the Northwestern CF program. He continues this work and has been a critical leader in CF research within and beyond the Therapeutic Development Network, or TDN, for the past 3 decades. Manu has authored greater than 100 peer-reviewed publications and helped lead important CF Foundation efforts like the Guidelines Steering Committee and other key initiatives. Within the TDN, he has chaired our Protocol Review Committee, which evaluates all research protocols submitted to the TDN and works with sponsors to optimize study design and conduct. This role has become critical over the past few years. Novel therapies such as nonsense read-through agents, phage, mRNA, and AAV vectors have started to enter clinical trials. He is also helping to lead our Genetic Therapies Working Group, a multifaceted effort to prepare the CF community and research teams to safely conduct genetic therapy clinical trials. Please join me in welcoming Dr. Manu Jain as he takes us on a journey to expand the horizons of new CF therapies.
Thank you, JP, for the very kind introduction. Hello, everyone. I'm truly sorry that we cannot meet in person, but I want to welcome everyone from around the world who is Zooming in today. So good morning, good afternoon, or good evening, depending on your time zone. It is great to be able to provide this update to all of you, which include people with CF and their loved ones, care teams around the world, and the scientists, researchers working hard to continue the amazing advances we have seen in CF over the past several decades. The title of my plenary is Expanding the Horizon of Therapies for the Underlying Cause of CF. So one of my goals today is to provide an update on additional groups of people with CF who can now benefit from highly effective modulators. But more importantly, my primary goal is to show the work that is being done to bring the benefits of treating the underlying cause of CF to those who are not eligible for modulators. By the end of my session, I hope that you'll be as excited as I am at the possibility of CFTR rescue for all people with CF, but also understand that much work remains to be done to bring this promise to reality. So here's my disclosures. So I have three objectives for today. I want to summarize additional people with CF who are now appropriate for CFTR modulation. I want to describe some non-CFTR therapies targeting ion movement, which may be applicable to all people with CF. And finally, I want to review the progress of genetic strategies to rescue CFTR, which are nearing clinical testing. But before I get to the core of my remarks today, I thought it would be instructive to frame them by looking at the history of CF. Important advances we've had in the past in traditional treatments, which have led to a substantial impact on the care of people with CF. One theme that ties together these traditional therapies is they targeted the consequences of CFTR dysfunction rather than the underlying cause. Nevertheless, they've had a tremendous impact, as you can see here. What I'm showing you here is median predicted survival in CF patients starting back in the late 30s, 1938, when Dorothy Anderson first described CF, and the subsequent improvement we've had over the 80 years since that time. As you can see, there's been a continuous improvement in expected survival. And what are the reasons for the survival? Well, you can see some of the reasons listed in the blue boxes here, which represent some of the traditional therapies we've had, such as antibiotics, mucolytics, and such. And on the yellow lettering, you can see some of the benchmarks in terms of CF care delivery and new information that we've learned about CF, such as a CFTR gene being mapped, all of which have contributed to this new era of CFTR modulators. So the underlying concept of CFTR modulation is that you can take an abnormal protein and use drugs to modulate it such that it works in a more normal fashion. And this has had a tremendous improvement in our outcome of our CF patients. But this took a lot of hard work. This new era is truly remarkable. But to get to this point was not easy and required sacrifice by many, including but not limited to people with CF, caregivers, scientists, and researchers. We have taken many shots on goal, and not all of which lets us score. But we have scored many times. Perhaps the biggest score occurred about 2 years ago, a little before our last in-person NACFC meeting, at which time the FDA approved a new breakthrough therapy for CF, ETI, or Trikafta. This treatment represented a new treatment that could be applicable to up to 90% of people with CF, many of whom had no previous modulators available to them. To really understand what these drugs have meant on an individual level, you really have to hear an individual story. And one such person is Mariah. Please join me in listening to Mariah's story.
All the others were down. Growing up with cystic fibrosis, I lived a relatively normal life. Other than me doing a treatment once in the morning, once at night before bed, and then taking my enzymes before each meal, I would say I was living a normal childhood, a normal teenage years, up until my freshman year in high school, where I went to the doctor and my lung function dropped dramatically. And I had to be admitted for double pneumonia. I just remember running into my mom's arms and giving her the biggest hug because she was crying as well, because we have never dealt with this, ever. And that was my new reality. Became my new normal, being in and out of the hospital. I actually was diagnosed with depression as well. I lost a lot of my hearing due to me being sick and the side effect from the antibiotic. I was sleeping a lot. I was missing class. I wasn't hanging out with people, mainly because I saw myself as less than them. And it's very sad to see yourself as less than somebody because you are human too. I think what I've been through has made me much stronger than who I am today. So it's made me appreciate life more, which has made me very bold, very sassy, and brave. When I learned that my mutations qualified for Trikafta, I was actually in the hospital for a tune-up and wasn't getting any better. And just an indescribable moment, because when you think that there's nothing else working, there's nothing else out there, and your doctor comes in with news that you are not expecting at all, you're just taken aback and you're just like, thank you. It's like, that was the greatest present anyone could have given me. My health has improved tremendously. I went from being considered underweight to in the normal category, just crazy to me. And I didn't need a feeding tube anymore. I was able to keep the food and the nutrients down. I had more energy to do so many more activities and participate back in sports, because due to me being sick all the time, I had to basically stop physical activity. And I restarted it. My lung function stayed stable. I was able to keep up with people. Other things that had been on the back burner, such as my hearing, they said, let's do it. So I got approved to do it, to get the cochlear implant. And the cochlear implant brought so much joy back to my life. I was able to complete my master's degree. And to be honest, I didn't know if I would make it to see that. I didn't know if I'd have the strength, the ability to be able to make it through that. My biggest cheerleaders in my life are my family. Without them, I wouldn't be able to get through all that I have gotten through. I do wish my mom was here to see me super healthy, but I know she's watching down on me, and I know she's here in spirit. I would be nothing without my family.
What an inspiring video. As discussed by Mariah, ETI or Trikafta has been transformational. I've heard similar stories from my patients and their family members and other caregivers in the CF community. It is clear that ETI has had a tremendous impact on lives of people with CF, whether you're looking at the physiology, quality of life, burden of disease, or a number of other parameters. We also expect that ETI or Trikafta will change the trajectory of our patients' lives for the long term. And we don't know that yet because it's only been approved for about 2 years. But we can look at the example of ivacaftor, which was approved 9 years ago, to see what we might expect to see with ETI over the long term. What I'm showing you here is data from a study that was published about 3 years ago, which looked at the impact of ivacaftor on death and need for lung transplantation. This is a study that was showed that when you were treated with ivacaftor, you had a nearly 85% reduction for need of lung transplantation over a period of 3 years when you compared it to a group that was not treated with ivacaftor. And then the risk of death or mortality was reduced by almost 60%, a relative risk of 0.41. So this shows that highly effective modulators have an impact on really important outcomes such as death and lung transplantation. Obviously, we don't know that about Trikafta yet, but it's something that we look forward to, and the ivacaftor example is intriguing. And we're going to learn a lot about ETI over the next several years. These are all the studies that are either convened or are going to begin soon that are going to look at various aspects of the impact of Trikafta. These are all either CFF supported or TDN supported. And when they're fully enrolled, we expect nearly 8,000 people to have participated in these various studies. Now, I'm not going to talk about all of them, but I will talk a little bit about this PROMISE study, which is being headed by Steve Rowe and Dave Nichols. The PROMISE study is a study that assessed the long-term impact of ETI on various clinical parameters And we know a little bit already about its impact on pulmonary outcomes, but this study will also look at additional outcomes such as GI parameters, impact on inflammation and chronic infection, as well as sinus disease. Now, at this meeting, we've got some initial data on the PROMISE study. The study is fully enrolled, and it'll include three cohorts of CF patients, as you can see on the left. One cohort are people who were on no modulators prior to beginning the study. A second group of patients were on 2 drug modulators, and a third group was on ivacaftor. What I'm showing in this graph is the impact on pulmonary function as measured by FEV1. As you can see, each group had a substantial improvement in FEV1. The group that had the highest improvement was the group that was not on modulator prior to starting this study. What's important to remember is that the patients who are on 2 drug modulators or ivacaftor had already accrued benefit from being on those drugs prior to starting this study. And the benefit we're seeing here is by the addition of ETR Trikafta on top of previous modulators. So it's heartening to see that in this real world study, we're mirroring the effects that we saw in the phase 3 pivotal studies. What about sweat chloride? Again, we see similar effects that we saw in the phase 3 studies. Patients who are not on a modulator or on a 2 drug modulator had about a 40 milliequivalent fall in their sweat chloride. And patients who were on ivacaftor had about a 25 milliequivalent fall in their sweat chloride. Now remember, this is on top of the previous decrease they'd seen of their previous modulator treatment. And this also roughly mirrors what we saw in the phase 3 studies. So it's heartening to see these results, and we look forward to seeing longer-term results from this particular study. Now, though we don't have long-term data on ETR Trikafta, we do have some hints that we may see some really important long-term improvement outcomes. What I'm showing you here is data from the CFF registry, and this represents the year 2020. And this is a median predicted survival going back to 1989 when I was starting my residency. And median expected survival at that time was 29 years of age. You can see that there's been continual improvement since that period of time. But then I want you to focus on the last data point on the slide, which represents the 5-year increment from 2016 to 2020, and the last year of which was when Trikafta was really introduced to most of our patients. As you can see, there was a tremendous increase in median predicted survival in that 5-year period, one of which was represented by Trikafta use. Now, 2020 was also a year where we socially distanced, wore masks, and were impacted by COVID-19. So it's hard to know for sure what the impact of ETI alone is or impact of other factors that may have improved predicted survival. Now, to look at the flip side, which is mortality, you can see, as shown in this slide, that mortality going back to 1990 was about 2% in the registry. That means that two people out of 100 in the registry died in that given year. Since that time, there's been a continual decrease in predicted mortality since that period of time. But then if you look at the last 2 years, the years covering 2019 and 2020, you can see that the mortality rate in the registry went from 1.2% to 0.8%, coinciding when ETI or Trikafta was introduced to the majority of our patients. Again, we can't say it's causal, but it is intriguing to look at this data and wonder what the long-term impact of Trikafta might be. And when you have modulators that work as well as the ones that we have available to us, it is all, of course, important to look at other people with CF who may benefit from this kind of approach. We know CF is caused by many mutations, up to 2,000 mutations. Many of the mutations, we don't know what the actual protein dysfunction is. But one thing we can do in CF is something called theratyping. In theratyping, we can take a mutation from a patient, introduce it into special cells called FRT cells, and then test these cells to see whether this particular mutation makes a protein that is responsive to a modulator, as depicted in this graph here. And if in this laboratory experiment, you can detect a response to a modulator, as evidenced by increase in CFTR function, then you can potentially use this drug clinically for a patient. And in using this kind of testing, the FDA was able to approve modulators for an additional almost 200 mutations, which meant that an additional 600 people with CF had access to modulators who prior would not have had access to this treatment. So definitely a very positive outcome from theratyping. So when you look at who became eligible through theratyping, and it's interesting to look at that group compared to who became eligible for Trikafta based on the phase 3 inclusion criteria. What I'm showing you on the left is the graph of the relative proportion of people who became eligible based on their background. And as you can see that about 80% of Caucasians in the registry became eligible based on the phase 3 inclusion criteria. When you look at communities of color, you can see the percentage was lower in Black patients in the registry and Hispanic patients in the registry, Hispanic patients barely being above 50%. Contrast that with the percentage of patients who became eligible based on theratyping. You can see that the number of the percentage of people who became eligible was much higher when you look at Black patients and Hispanic patients compared to Caucasians. So this theratyping label expansion benefited tremendously patients who represent communities of color and is an advantage of theratyping, as you can see here. So one of the thoughts in the management of CF patients is that if you can modulate CFTR function at a younger age, you may get better longer-term outcomes. The idea being that if you can prevent some of the complications of CF, as opposed to treating the established complications, you might get better longer-term outcomes. So with that in mind, we were heartened and excited to find that ETI or Trikafta was approved for 6 to 11 years of age in June of 2021. This approval was based on data that I'm going to show you here. In addition to being safe, we found that there was about a 12% improvement in FEV1 as shown in this graph. One of the unknowns going into the study was whether patients who are younger and have a higher baseline lung function, in this case 89%, would they still have an improvement in FEV1? But as you can see here, they had about a 12% improvement in getting a FEV1 to nearly 100% of predicted. And then when you look at their sweat chloride, you can see they also had a tremendous decrease in sweat chloride, a mean fall of about 60 milliequivalents, getting below the diagnostic threshold of CF and a little bit higher than we saw in the older age groups. Now, why the younger age group might have a greater fall in sweat chloride, we don't know, whether it relates to higher drug levels that can be achieved in smaller patients or whether there's more CFTR available to rescue. We don't know the reasons for this, but it is interesting, something we'll track going forward. Well, what about even younger patients? Well, we were able to get approval for ivacaftor for patients as young as 4 months of age in 2020. Now, obviously, patients that young, we can't measure pulmonary function, but we can measure a couple of other parameters which help us understand its function. So when you look at sweat chloride in this population of infants, you can see that ivacaftor led to a 60 milliequivalent fall in sweat chloride, again, below the diagnostic threshold of CF, and a greater fall in sweat chloride than we saw with our with our older patients who were treated with ivacaftor in the original phase 3 studies. Another parameter that was assessed in this group of infants is pancreatic function. And what was measured was the change in fecal elastase, which assesses pancreatic function. And after about 18 weeks of treatment, that you saw a 200 microgram increase in fecal elastase. Now, this represents the diagnostic threshold of separating patients who are pancreatic sufficient compared to patients who are pancreatic insufficient. Now, it had been thought prior to this work that the pancreas was perhaps damaged irrevocably and could not be rescued by modulators. But this kind of data suggests that maybe that thinking needs to be altered and that there may be some residual pancreatic function that can be rescued. This is something we'll look forward to as time passes to see how long this continues to exist. So with that in mind, when can we expect to see ETI approved or available for our very young patients? Well, obviously, we don't know the answer to that, but if we look at CFTR modulator development timelines, you can get a sense of when that might happen. Ivacaftor was first approved in 2012 and then made it down to the very young infants in 2020, so about 8-year time period. Lumacaftor, ivacaftor was approved in 2015 and has been progressing to a younger age group. And ETI was approved just this year for the 6 to 11. There are ongoing studies of ETI or Trikafta in the 2 to 5, Lumacaftor, ivacaftor in the 1 to 2-year-olds. And we'll look forward to studies in the very young patients for ETI in the next few years. This gives you an idea when we might expect to see those studies. I'd like to finish off my modulator portion of my plenary to mention a couple of other programs in development. AbbVie Pharmaceuticals has a triple combination that they're testing in 2 studies. One is a dose ranging study where they're using a potentiator and 1 corrector. And this study is ongoing, and we hopefully will get some results sometime in the next several months. And they're just starting a study of their own triple combination, which is being started in Australia. And we hopefully will see some results in the next several months of that particular study as well. And Vertex has a new triple combination that is already being studied. And the new triple combination represents a new corrector and a modified potentiator, such that this is a once-a-day regimen. And this is going to be compared to Trikafta in an ongoing study, which we'll expect to see results from in the next several months. Now, one concept that is important to understand about modulators is that you actually need protein to be made, even though it's dysfunctional, for it to work, for them to work. Now, there are some patients who don't make any protein at all. These patients have what are called nonsense or class 1 mutations, which make little or no mRNA and no protein. So modulators are not an option for them. But we do have approaches that might work for these patients. And these are called nonsense suppressors. Now we've known for many years of research that there are certain antibiotics that can work in this kind of a patient because they bind ribosomes, and they bind ribosomes in a way that allows read-through of these premature stop codons such that you can have a full-length protein made. Now, this protein may not be fully functional, but it does have some function because it has a full length. Now, using this approach, Elux Pharmaceuticals was able to leverage their platform, which they call the eukaryotic ribosome-specific glycosides, sort of mirroring aminoglycosides, but they were able to modify these molecules such they were able to improve efficacy and reduce the toxicity related to the previous modulators, the previous drugs, and test them in these patients. As proof of principle, they were able to provide this data. They took cells from patients with CF expressing one class 1 mutations, G542X, and tested the impact of ELX-02 in terms of rescuing CFTR activity, what I'm showing you in the green. And when they exposed these cells to ELX-02, they had an increase in CFTR activity as shown in the green. Interestingly, when they added VX-770, which is ivacaftor, they got a further augmentation of CFTR activity using the potentiator effects of VX-770. So this suggests that this combination might be able to use together in patients, and is the reason that another cohort of an ongoing phase 2 study is testing the combination of ELX-02 and VX-770. So we're expecting some results from this phase 2 study, which has been recruiting for a while now. We may see some results at the end of this year, hopefully. So these drugs have obviously been transformational. There's no question they've helped many, many people. However, there's still many people with CF who have not benefited from such transformational therapy and are looking for their own new transformational treatments. One such person is Livy, who I've known for several years. And I'd like to introduce you to Livy and have her share her story as she waits for her transformation. Livy?
My name is Liv, and I'm currently a first-year law student at DePaul University in Chicago. I want to do medical malpractice. I'm not sure if I want to do defense or prosecution, but I definitely want to go into something with health law. I feel like at a young age, I was always getting hospitalized. I had a surgery when I was a baby, and they just kept continuing from there. So it was always with me growing up, and it was always something that my friends were aware of. Living with cystic fibrosis is challenging. I'm normally used to being hospitalized 3 to 5 times a year from catching a virus or from having a pulmonary exacerbation. This makes it difficult with missing school, and it definitely takes an impact on my mental health when I'm not able to see my friends and family. My CF mutations don't benefit from any of the modulators currently on the market, but I got an opportunity to be in a clinical study where they would swab my nose and grow my nasal cells out and then test the current modulators on those. Unfortunately, they didn't work. I was obviously very upset. That was something that I was pretty confident in that I was going to work. And my family was too. We had been looking forward to it. We were excited. So that opened a gateway to other clinical trials that I was able to get involved with. I've participated in one trial before for cystic fibrosis, and I'm currently in one for a new genetic therapy. I was initially hesitant to participate in a new clinical trial because it was a drug that wasn't FDA approved, and I was scared that it would come with long-term effects. But the research team was able to reassure me of everything and explain the technology in the drug before I consented to anything. So I'm very grateful for them and how they guided me along this process. The most important thing for me in participating in this trial was that it would not only benefit me, but other people with CF who don't qualify for the modulators. It definitely can be hard when I hear about people with CF that are on the current modulators, and when I hear that their lung function has improved and they haven't been hospitalized. But it also, at the same time, makes me optimistic about what could come for me. For anyone contributing to the research for genetic therapy and CF modulators, I just want to thank you with the utmost gratitude, because people like you are the reason that people like me with CF have hope, that CF will stand for a cure found.
So thank you, Livy. So who are the people that need additional treatment options, such as Livy? Well, clearly, people who have a genotype that makes them ineligible for highly effective modulators are definitely in need for additional treatment options. There are also people who begin on modulators but can't continue to take them because of side effects or other adverse events that preclude them from continuing on a modulator. So they clearly need additional treatment options. There's also people who may have a relatively modest clinical effect, maybe not the huge effect we see that in many of our patients, and they're still looking for additional treatment options as well. And finally, you can make an argument that every CF patient needs additional treatment options. As effective as modulators are, they're not curative. Our patients may still have bronchiectasis, chronic infection, exacerbations. So an argument can be made that every CF patient needs additional treatment options if we're going to get to our hope of a cure for everyone. So who are these patients that they're ineligible for ETI or Trikafta as we assess in the CFF registry? So what I'm showing you is data from the registry broken down by communities that are ineligible for ETI. And as you can see that about 10% of Caucasians over the age of 6 are ineligible based on their genotype. But when you look at communities of color, you can see that the percentage is higher in Blacks and Hispanics. Hispanics, almost 22% of patients in the registry ineligible for ETI or Trikafta. So clearly, these patients representing communities of color are at a disproportionate need for additional treatment options. Another way to look at these communities, these patients who are ineligible, is to look at a geographic map that I'm showing you here. Now, this represents all the CF centers around the country with a relative proportion of their population that is ineligible. The size of the circle represents the number of people they have at their center that are ineligible for a modulator. And as you can see, while every center might have some patients, there are clearly some centers that have many more patients who are ineligible compared to others. So what's the implication of this? Well, this might have implications for how we do our trials and we try to enroll patients who are ineligible for modulators. It may be that we have to regionalize these trials to centers that have high numbers of patients and set up referral programs and communication across different centers so we can effectively enroll for these kinds of studies. This is something we're going to have to look at as a community, and as a TDN network to see how we can do these trials. So we know that CFTR's primary function is as an anion channel, of which chloride and bicarbonate are perhaps the most important. An alternative approach is to look at non-CFTR molecule that can replicate some of the function of CFTR. And one such molecule that has been looked at is something called TMEM16. This is a protein that also is a chloride channel that also sits in the apical membrane of airway cells and is also predominantly expressed in secretory cells. And there's a compound that's been developed called GDC6988, which also has had other names in the past. And it is designed to increase chloride movement through this TMEM16 molecule. Do we have any evidence that by activating TMEM16, you may actually get some positive effects in CF patients? Well, I'm showing you data from a couple of different experiments. On the left is an experiment in which they took cells from a CF patient. So we know CFTR is not being expressed or functional. And they exposed these cells to GDC6988, activating TMEM16. And what you see there in the red is that there was an increase in the ASL, the airway surface liquid height, which we know is important for optimizing mucociliary clearance. So this is proof of principle that by activating a different molecule, we're able to get effects that will be positive for CF patients. And on the right, I'm showing you data from an animal model in which they were given a CFTR inhibitor to reduce mucociliary clearance. But then when they treated these animals with this compound at higher dosage, you saw a greater effect on mucociliary clearance, demonstrating a pharmacologic dose response effect. So this suggests that by activating this other protein, you may be able to treat all patients with CF because this would be a genotype independent mechanism. So something that we're going to look forward to. Trials of a dry powder inhaler are planned for sometime in the next year through Genentech. Another approach which is interesting is something called molecular prosthetics with amphotericin B. Now, many of you may have heard of amphotericin B because it's used often as an antifungal in different contexts. Now, the idea behind using amphotericin B is that it gets into the airway, it gets into the epithelial membrane and creates novel, new channels through which chloride or bicarbonate could move. And so this is the idea behind a molecular prosthetic. What's the evidence that it might actually work for CF patients? Well, I'm showing you data from an experiment in which cells were obtained from CF patients, and they were exposed to amphotericin in the laboratory. And what you saw was that with treatment with amphotericin led to an improvement in the pH of the airway surface liquid. We know this is important for optimizing the antimicrobial function of ASL fluid. We also saw in the slide on the right a decrease in the viscosity, which is also abnormal in CF patients, and a decrement of viscosity was also something that's important for the management of CF patients. And then finally, we saw in an animal model of CF that when they were given nebulized amphotericin, that you were able to bring the pH into a more normal range, again, consistent with an salutary effect that we might be able to see in CF patients. Now, there's the key limitation that we have with amphotericin B is its toxicity, which can limit the amount of amphotericin you can give to a patient. But systemic medicine has leveraged an extensive series of mechanistic studies and adapted amphotericin B in a way that allows you to give higher doses without inducing any the toxicity that you see with normal amphotericin B. And using this approach, they are planning on clinical trials sometime the next year in the CF patients. This approach would obviously be applicable to any person with CF. Now, while non-CF targeting therapy may be beneficial, the goal, of course, is full restoration of CFTR function. The possibility of gene therapy has always been tantalizing since the CFTR gene was discovered in 1989. Now, since that time, many different therapies have been done to evaluate gene therapy. And while none have come to fruition in terms of a treatment that we can do, we have learned quite a bit, which will inform upcoming genetic programs. And the programs now in development will target both mRNA delivery and gene delivery using DNA. But before I talk about those programs specific, I thought it would be important to make sure we're on the same page. So let's take a minute to look at the video that explains how these therapies are supposed to work.
One treatment being developed is RNA therapy. When the CFTR mutation appears in a patient's DNA, it also shows up in the messenger RNA, which is a replica of the DNA sequence. This mRNA carries instructions out of the cell nucleus to ribosomes in the cytosol, where proteins are made. Mutated RNA makes a non-functional protein, too little protein, or no protein at all. If successful, RNA therapy would either replace the faulty messenger RNA with the new mRNA with the correct instructions, or repair the defective RNA. Once inhaled into the lungs and entering airway cells, new messenger RNA would be able to make normal, functional CFTR protein that moves to the surface of the cell, where it adjusts the amount of salt and fluids flowing into the airway space. One possible way to restore CFTR protein is gene transfer. Gene transfer would work by inserting a normal CFTR DNA sequence into the cell, so that it can make functional CFTR protein. Gene therapy could be inhaled or given through an IV. However, getting DNA into lungs is challenging. Cells are surrounded by protective membranes that are designed to keep out foreign objects. And in the lungs of people with CF, cells are also covered with a thick layer of mucus. Specialized delivery mechanisms called vectors are being developed, which would take the new correct CFTR gene into the cells. There are multiple types of vectors derived from viruses or synthetic molecules. Gene transfer could potentially work on anyone with CF, no matter what kind of mutation they have.
So now that we're on the same page, the tantalizing potential of genetic-based treatment has always been the holy grail for CF. Now, we've learned quite a bit over the last several years, and there are a number of programs in development trying to develop either an mRNA-based approach or a DNA-based approach, which are nearing clinical testing. I want to spend the rest of my time providing an update on a number of these programs. Now, the mRNA programs I'm going to talk about are through Arcturus and Recode. Now, you are probably already aware of Translate Bio, which has already done their phase 1 studies. The DNA-based programs, which use a viral vector to deliver a normal CFTR gene that I'm going to talk about, are 4D Molecular Therapeutics, which uses an AAV vector, Spiravant, and Crystal Biotherapeutics. So the first program we'll talk about is Recode Therapeutics, and they're using an mRNA approach. So there's two components of the platform that they're developing. One is, of course, the normal CFTR mRNA, which is modified and optimized for expression in airway epithelial cells. The second component of this platform is a lipid nanoparticle. Now, it's really important that you optimize this nanoparticle in order to make sure it's stable for nebulization, that is high quality, and its translation efficiency is optimized as much as possible in order for airway delivery. So Recode has been able to provide this data suggesting efficacy. So what I'm showing you here is data from an experiment in which they took cells from a CF patient and exposed this mRNA lipid nanoparticle to these airway epithelial cells from a CF patient. And as you can see, when they gave this compound, they were able to get a substantial improvement in CFTR function, as shown in the orange line there. In comparison, you can see the effects that we're seeing with Ocambi, which is VX809, which is the blue line, or with Trikafta, which is the red line, showing that a substantial increase in CFTR function when these cells were exposed to this mRNA lipid nanoparticle. So this is proof of principle that this platform can actually get into airway epithelial cells, make CFTR protein and have it function in a normal fashion. Now, there are ongoing preclinical studies, but they're anticipating starting their clinical program sometime in the next year or so. A second program that is also targeting mRNA is through Arcturus Pharmaceuticals. And they have dubbed their compound Lunar H-CFTR, but it has a similar approach in that they're using a lipid nanoparticle there that they've developed on their own, also optimized for airway delivery and efficient transduction of mRNA. And they show experiment here in which they took cells from an animal model, which was expressing the G551D mutation. As you remember, G551D is a gating mutation that responds to VX770, which is Kalydeco. And in this experiment, when they gave a low dose of this compound, they were able to get some restitution of CFTR function. But at a higher dose, they got a substantially increased amount of CFTR activity as shown in the blue line. For comparison purposes, you can see the impact of ivacaftor VX770 on the same cells. And this gives you some idea of the magnitude of effect they were able to get with this compound. So this program is in an advanced preclinical stage, and they're hoping to start clinical trials sometime in the next year or so. What about the DNA-based programs? Well, one of the things that is important for a DNA-based program that's using a virus is they really need to optimize viral vectors such that they can get efficiently into the airways, get through the mucus, and bind effectively to airway epithelial cells and get the gene transmitted into the cell. And so 4D molecular therapeutics has spent a substantial amount of time optimizing what we call capsids. These are the protein lining of the virus, and it really impacts whether a virus can get into airway epithelial cells. So they've spent a lot of time developing these capsids and have identified 40 or so that are optimized for airway delivery. And using these capsids, they've been able to show this kind of effect. On the left, I'm showing you an experiment where they took cells from a CF patient and exposed it to 4D710, which is what they call their DNA compound. And they were able to show that in a dose-response fashion, shown on the graph on the top, they were able to get CFTR expression. They were also able to show that in a non-CF cell, they were able to get exogenous CFTR expression compared to normal CFTR, which was made by the cell itself. You can see down at the bottom. And then interestingly, in an animal model, they were able to give this compound in a single aerosol dose of their 4D710 compound. And they looked for evidence of CFTR expression in the airway epithelium. And as you can see on the pictures at the bottom, I want you to focus on the right where the 4D710 data is. You can see all that brown staining represents CFTR expression in the airway epithelium, both in the trachea and the bronchial epithelium. So this is evidence that they were able to get this vector into the cells and get CFTR expressed. Importantly, they also showed that this was well tolerated in this animal model, and they didn't see much evidence of inflammation, suggesting that this is moving forward to clinical use. Now, they are hoping that they can develop advance enough their preclinical work to start clinical trials sometime in the next year or so. A second program is being performed by Spirovant Pharmaceuticals, and they have a similar approach in that they have an adenovirus-associated vector, which has also been optimized for airway epithelial delivery. And they've dubbed their compound SP101. And they've done experiments in which they've taken cells from CF patients and exposed them to this SP101 in a dose-response fashion. And what they were able to show in this experiment is that they were able to get evidence of of increased CFTR function, as shown in the bars there, in a dose-response fashion, suggesting a pharmacologic effect. And then in an animal model, what they were able to show is that when they gave a animal this SP101, they were able to detect after 2 weeks CFTR expression in the epithelium of these animals. In terms of duration effect, they've done experiments in a non-CF animal and have been able to detect CFTR expression up to 12 weeks after nebulization of SP101, suggesting a durability of effect. Now, they're continuing to do their preclinical studies, but are hoping to begin clinical trials sometimes in the next year or so. A third company developing a DNA-based therapy is Crystal Biotherapeutics, and they're using a slightly different approach. The virus that they're using is HSV1, which has been modified to make it safe for human use. And it also includes 2 copies of CFTR. And they've shown experiments where they used human organoid, CF organoids shown here. They obtained cells from patients, 2 different patients, both of whom were homozygous for class 1 mutations shown here. And these cells were grown into organoids, which are spherical structures, which when CFTR is produced and active, the organoids will swell. So when they took these organoids from these patients and exposed them to KB407, which is the name of their compound, they were able to show that in both instances, the organoids had increased swelling as evidence of CFTR, active CFTR protein function. This is obviously exciting data. And even more exciting is the recent approval that they were able to get from authorities in Australia, and they're planning on beginning phase 3 trials this year. So as we learn about these programs and as they near clinical testing, we have to think a little bit how these trials are going to be done. One of the challenges that we're going to face is that the people with CF who are going to be eligible for these trials are going to have relatively low prevalence mutations. What this means is that we are not going to be able to do the classic large phase 2, phase 3 studies with a large number of people with the same mutations. So perhaps what this means is we're going to have to think globally in terms of doing these trials. What I'm showing you here is the relative prevalence of CF across the world in different countries. And maybe it's time that we think about combining forces across the countries, joining forces with different trial networks so we can ensure adequate enrollment, so we can get robust efficacy and safety data to bring these to clinical fruition. In addition to those challenges, there are other challenges that we need to think about as these platforms become the clinical trials. What is the level of evidence we need to see from preclinical experiments to have some confidence that this will actually work in our patients? What are the long-term safety effects of these genetic platforms? Are there off-target effects? What is the impact of concomitant medications, which often need to be given to ensure adequate expression of these genetic therapies? In many studies, human volunteers are the first people to test a drug, but this may not be true for genetic-based therapies, where the first studies may be done in CF patients. And we already talked about this concept that the eligible population is going to be small, which becomes even more important when you think about the impact of participating in one trial and how this impacts your eligibility for future trials. So we really need to be thoughtful about how we recruit for these particular studies. Well, these are obviously difficult questions to answer, but to help us reach that, get some consensus around these questions, the CF Foundation, with the leadership of J.P. Clancy, has convened a genetic therapies working group, of which Chris Goss and I are chair. There have been 4 subgroups that have been identified that will work on various aspects of these questions. 2 of these subgroups will focus on educating either the CF community or the research managers and research people who, and that will be their focus. The focus of the preclinical group will be to establish the kinds of experiments we need preclinically to start clinical trials. And the clinical subgroup is tasked with trying to develop programs to how to adequately test these drugs in a clinical setting. And they will all coalesce to provide educational programs for our care teams. Because what we do know is that our patients and families rely on their care teams to get the most information, the most important information. They trust them the most. And so we need to make sure that our care teams are adequately educated in terms of risk benefits of these genetic strategies so they can inform our patients and families. So this is an endeavor that we're going to look forward to the next year or so. So now that I've come to the end of my plenary and we peer into the beautiful horizon, I think it's important that we celebrate the many successes we've had over the past several years. But I also hope it evokes the idea of us continuing to look forward as a community. The clinical trials of genetic therapies which are coming will no doubt create new and likely unexpected challenges. I'm confident, though, that given the combined talents of our CF community and our energies, we will reach that horizon of cure found. Thank you very much.